everybody. Thank you for joining us for the September Enterprise Risk Management Toolbox webinar, although it is taking place on October 1st. This month's topic is the Healthcare Professional Liability Program costs, self-insurance versus private insurance. A couple of housekeeping notes before we get started. If you've dialed in by phone but haven't logged in by computer and you'd like to see the slides that will be shown, please point your web browser to readytalk.com. In the box where it says Participant, Join a Meeting, enter the same access code that you used to join the call, 987-9821. Please stay aware of the level of background noise in your area, and if it starts to become noisy, please put your phone on mute. If your phone doesn't have a mute button, you can use the ReadyTalk controls, which are *6 to mute and *7 to unmute. Also, I will be monitoring the phone lines and can individually mute lines if we have problems with background noise. If you're called away from your phone, please don't put your phone on hold because that will transmit your hold music to everybody else on the call. You can simply hang up and dial back in when you're available. We are leaving the phone lines open, so if you have a question, you can ask it as it comes up. Also, the chat box is available if you'd prefer to enter your question that way. Just type it in, and I will relay it to our presenter when we have a moment. And to introduce our presenter, Mike Harrington is the Director for Property and Casualty Actuarial Services at Bickmore Risk Services. He has over 20 years in the actuarial field and is a Fellow of the Casualty Actuarial Society and a member of the American Academy of Actuaries. He is also a UC alum, graduating from Davis with degrees in mathematics and economics. Mike?
Thank you very much. You'll notice, everyone, that I did not put actuarial in the title of the presentation. That was kind of in hopes that I would actually get some people to join the webinar this morning. So hopefully you won't be disappointed. It's always good to start the morning out with a good actuarial presentation. As we go through the presentation today, if you have any questions, just be sure to either put them in the chat box or go ahead and call them out as they come. Our kind of the outline for today, we're going to talk about self-insurance costs, the self-insurance program for UC. Some of you who may have seen me present before, some of it will be a little bit of what you've seen before in terms of figuring out what the total costs of the system are and allocating them down to the campus level. We'll look at some loss trends. And then what we'll also do at the end of the presentation is we'll provide a comparison with the costs of providing this coverage through private insurance. We'll look at some of the carriers involved, what the coverages are that are out there in the market, and what costs that they include. And then we'll provide a comparison of costs between the self-insurance program with UC versus what similar coverage would cost outside the program. But since we are going to be going through some trends, we'll be looking at some graphs. So what I wanted to start you out with is just to get you primed and ready to go for the presentation. We'll look at some sample graphs, and graphs tell lots of stories. So we'll start out with one talking a little bit about health. As you can see here, a pie chart's a good way to show when diets start. Very few of us actually started yesterday. Many of us plan to start it later today, but most of us plan to start our diets tomorrow. Thus we can see the large red chunk there. I can sense you're all laughing in hilarious, uncontrollable laughter out there. Don't worry, there's even more, because when we look at beauty, this is the graph that shows the people that think I'm handsome. You can see half of it is my mom, half is my grandma, and you will notice that my wife is not shown here. An unfortunate part for this graph. Finally, just treating education. A lot of people seem to have a lot of problems with math, and some of the problems are shown here. They can't read their handwriting, that's about 25%. Dyslexia is 20%. Some of them fall asleep. I don't understand how. It's 5%. Dog ate the math book's 5%. A lot of them can't just create a correct pie chart. That's 75%, which, as you can see here, a pie chart's supposed to add up to 100%, but I think we have about 130% here. So there's some graphs to get you charged and ready to go. And what we'll start off with is some historical trends. We'll look at the frequency, severity, and the loss rate for the Med-Mal program. Our first graph shows the claim frequency trend. This shows the frequency per 10,000 risk-adjusted exposures. Later on in the presentation, we'll talk a little bit about what risk-adjusted exposures mean, but you can kind of think of it as per 10,000 beds. That's kind of a good way to think of it. And you'll notice that the frequency trend for the first 5 years shown here, kind of oscillating around 160 or so claims per year per 10,000 risk-adjusted exposures. And then we had a declining trend from 06-07 through 9-10, and now we've kind of leveled off at around 120 claims per year. So we saw that favorable trend there for a little bit. Now it's kind of flattened out, which is a good thing. We've seen a lot of other coverages where frequency is starting to go up, so it's at least flat is good. So that's the number of claims that we're having per year. Now if we look at the average cost per claim, you can see that's been pretty variable. And the claim severity is what we refer to that as. It's the average cost per claim. And so you notice back in the early 2000s, we had a decreasing trend going on, dropping from about 60,000 down to around 45,000. Then we started the uphill climb again. We had a couple years, 07, 08, 08, 09, which had some large claim issues, and so they had some pretty high severities there. But in general, since 05, 06 through 11, 12, 12, 13, you can see a pretty constant rise in the average cost per claim. And when you put these together, you see the loss rate trend. Now the loss rate is defined as the amount of loss per risk-adjusted exposure. So you can think of it as, again, the cost per bed. And early on, you can see we had flat, if you recall from a couple of slides ago, we had flat frequency, decreasing severity. So those kind of translated into that decreasing trend we see in the first 4 years. And then we've kind of mimicked that going forward, that severity trend, where 07, 08, and 08, 09 are also high years, again driven by the large claims in that year. And the most recent few years, you can see a pretty steady increase in the loss rate trend. And these numbers are from the most recent actuarial report. So we projected 12-13, fiscal year 13, the average cost per bed to be $875. Now that's really our starting point. We look at those trends, and when we're trying to figure out the cost of the self-insurance program and project it forward to next year, we have to look at these loss rates because we don't have any loss information yet for next year. So when we did this analysis, we were projecting forward to 13-14. So we had to start with the loss rate selection, 875, and now we will take that 875 and use it to estimate our 13-14 program costs. You'll notice here on this slide, the first line here, we've got the 875 is from the prior slide. We take a loss trend factor, and we're using a 5% assumption of annual inflation per year. That again is based upon, as we looked at that that prior trend slide, that increasing trend we've seen in the last 6-7 years. And so to get from that 2012 level of loss rate to the 2013 loss rate, we added 5% and gets us to about 919. Now when we did that original analysis, that was only including claims up to $750,000. So the self-insurance program for UC takes us all the way up to $5 million. That's the self-insured layer. And so on top of the 919, which would just be the average cost for the $750,000 coverage, we add another 57% to get us to $1,441 per bed, essentially. And that $1,441 represents the average cost per bed to cover everyone up to $5 million per claim. Now again, since we're looking forward to 13-14, we don't have any loss information at the time we did the analysis to make these picks. So we have to assume a loss rate that's appropriate for next year, which is that 1,441, and then we make an estimate of what the risk-adjusted exposures are. And that's 31,400. It's essentially bed equivalents, but what we do when we calculate those risk-adjusted exposures, we don't just have beds within the campus, within the med centers. We have physicians, we have surgeons, we have all of these different folks that are treating the patients, and each one of them creates their own exposure. And so we take all of those exposures and have to convert them to a constant basis so we can add them all up. And so when we add them all up, they come up to what's called a occupied bed equivalent, and that's what we're talking about here. So if you took all the doctors, you took all the physicians, you took all the residents, and all of the various pieces that contribute to the risk of med mal claims, combine them all, it's equivalent to 31,400 occupied beds per year. That's kind of the way to think about it. And you can go ahead and forget that now. We'll do a quick example of that later on in the presentation of how we come up with that number. But the bottom line is, we've got the $1,441 per bed. We're estimating 31,400 beds, so we multiply those guys together, and we come up with a total estimated claim cost of $45.3 million. That's kind of our starting point. That's covering everything up to $5 million bucks. We estimate that the total cost for the UC system will be about $45.3 million. But we also estimate that as a result of some loss prevention measures and initiatives that have been put into place over time, about $4.4 million worth of savings. And also, we're not going to pay all this money out at once. It's going to take a number of years for all these claims to be reported, paid, and closed, and so we get the benefit of the investment income of $6.5 million. So when we take those guys out, what we end up with is $34.4 million bucks of discounted claims costs. And that's at the expected level. So you need to think of that as kind of your flip of the coin number. Half the time it's going to be enough, half the time it's not. So we bump in a margin for potential adverse outcomes. And so although we expect $34.4 million, we within the premiums we add in a little bit of a margin. You can see here it's about $3 million bucks to get us to the 65% confidence level. So basically all this page does is gets us to how much do we anticipate the claims themselves will cost for 13-14, for all those claims that occur in the 13-14 year. Now that's just one piece of the cost puzzle that gets allocated out to the campuses. If we take that 37.6, bring it over to the next page, we add on some additional loss prevention expenses of about $1 million. We have other program expenses that are necessary to carry out the self-insurance program, including a TPA to handle the claims, take the claim reports, make the payments, etc. We have insurance costs, and here's where we have even more coverage being provided by the self-insurance program. Everything we talked about already is covered up to $5 million per claim, but on top of the $5 million per claim, there is additional insurance purchased to cover the layer up above $5 million. And we've had that up over $200 million per claim. So you have quite a bit of coverage through the self-insurance program, not just the $5 million, that's how much UC keeps itself, but over and above that, insurance is purchased for even larger claims. And then finally, you have other administrative expenses for running the program. and that totals total program expenses of $15.3 million. So on top of the claims cost we have up top, loss prevention expenses and other program expenses, we wind up with $53.9 million worth of necessary funding to keep the program running. So now we know what the total cost is. How do we divvy that up between all of the various campuses? Now the process is very mechanical. What we do is we look at your loss experience, we look at the exposure measures for each individual campus, and by experience we're talking about losses, how much incurred losses or paid losses are there at the campus level. For exposures, again, we're talking about this adjusted exposure that takes into account the number of physicians, the surgeons, the beds, the surgeries, etc., and bring that all into a common measure for exposure. Now for the experience, what we do is we actually break up this allocation into three pieces. We have a primary portion, which covers the portion of the loss below $250K. We have a mid-layer that covers the portion of the loss between $250 and $1 million, and an excess portion which covers everything above. So the example I'm showing here, if you had a $5 million loss when we're calculating these allocations, that $5 million loss gets cut up into a $250K piece in the first layer, $750,000 in the second layer, and then $4 million in the excess layer. And then when we do the allocation, we're going to look at those three layers separately. Now again, the exposure, this is where we'll get a little bit more detailed. For the exposure, we use physicians and surgeons, and we take whatever hospital statistics, such as the number of surgeries, the number of beds, and we have to take all of these exposure measures and convert them into numbers we can add up, because physicians and surgeons and visits and surgeries are apples, oranges, and bananas. So we got to convert them all to apples so we can add them together to see what the total exposure is. And so when we combine them, we convert them to what we call an occupied bed equivalent. And we use a number of factors to do that. So I'm sure that made a lot of sense. So what we'll do is we'll go through a specific example of how you would actually go about calculating that. The exposure for each FTE we're going to convert to this occupied bed equivalent by using relativity factors. So the examples we show here, you have you have three primary care physicians. Okay, their relativity is 2.0, meaning that relative to an occupied bed, one primary care FTE is twice as risky as one occupied bed. Now we have three primary care physicians at that relativity of 2. Now OBGYN we know is a more risky specialty. The potential costs with the claims related to that specialty are much larger. We have 2 OBGYNs, and you can see their relativity is 12. So they're actually 12 times as risky as a single occupied bed. Or you can even look at it as they're 6 times as risky as a primary care physician, based upon that relativity. We have 5 average occupied beds. And so you can see the relativity is 1. That is our base case for the exposure calculation. Number of office visits, we have 1,000. Yeah, you'll notice it's really quite a strange clinic we've got going on here with 3 primary care physicians, 2 OBGYNs, and 1,000 office visits. But the math all works out. So the relativity for the office visits is 0.001. So basically it takes 1,000 office visits to be equivalent to 1 occupied bed. And then on deliveries we have 100 of those, and their relativity is 0.02. So how do we use all these numbers? Well, I'm going to show you. We calculate this risk-adjusted exposure by taking the primary care FTEs. We had 3 of them, and their relativity was 2. We multiply them together, we get 6. So there are 6 There are 6 equivalent exposures for primary care. For OBGYN, we had 2 of them, and their relativity was 12, so we have 24 equivalent exposures. The occupied beds were 5. The office visits were 1,000 times their factor, which is equivalent to 1. And the deliveries, they had 100 times their factor, which is equivalent to 2. So now we just add them up, and you can see that our risk-adjusted exposure is 38. And so, not that we need to memorize the facts and the bells and whistles out of this. The one thing I want you to take out of this, though, is we have to take primary care physicians, OBGYNs, office visits, deliveries, etc., a number of other exposure measures, and we have to convert them into some numbers that we can add up and call our exposure. And so this is that methodology that we use to do that. So before we get going into the next step, we'll do wake up, because we're going to do some more graphs. You can talk about transportation with graphs. So when a song comes on your radio, it rarely is it when you want it to. It's usually when there's other songs on other stations, or as you get to your destination, you got to get out of the car. I think that's pretty true. How fast do you think you're going? Now, I've been through each one of these age groups, so I can attest to them. As a teen, you don't think you're going near as fast than you really are. As an adult, you kind of have a good idea. But when you get older, you think you're going a lot faster than you really are. So again, you can express a lot of these concepts in a graph, and this one here I think is the most true. Is when you're in heavy traffic, the speed of the cars in my lane are always the slowest. Even if I change to the other lane, they're always going to be the slowest. And so with that, we're going to take we're going to look at some additional graphs that show how we break up these cost allocations for the different campuses. And again, everything we've done so far is to come up with the total cost. Now we're going to take that total cost and allocate it to the campuses. So if we look at our historical experience by year, you can see here that, and these dollars are in millions, we've ranged all the way from $30 million of loss in a year to almost $60 million of loss in a year. And that's pretty common given the large retention that UC has on the self-insurance program. When you cover up to $5 million per claim, there's a lot of room for variability. And so we take that variability, and it's reflected here. As we talked about before, when we do the allocations, we're actually going to take each one of those years and we're going to break them up into 3 pieces. We're going to break them up into the primary layer, which is those claims below $250K. We're going to break them up into the mid layer, which is from $250K to $1 million, and that excess layer, which is the piece above $1 million. And so each one of those years, same bars that we looked at on the prior slide, now we've broken them up between the primary, mid, and excess layers. Now these are the numbers that we ultimately will use to do our cost allocations. So when we do these allocations, we take the experience group, either primary, mid layer, or excess, and we allocate it to each campus in different ways. Now the first step, the primary allocation, that first $250K layer, that's where you have most of your action. That's where all the claims are going to occur. You're going to have claims that are $5,000 in there. You're going to have claims that are $1 million, but you're only going to include $250K in there. And since that is really our first layer of loss experience, we allocate that layer of loss to each campus based upon their loss experience only. So we look at every campus's loss experience capped at $250K, and however that distribution falls out, that's how we allocate it. It's easier now. We'll drop down to the third piece, the excess piece. Everything over $1 million. Now we're talking about very fortuitous losses here. These are the kind of claims that you know about. You know them by name. You know the claimant. They're those ones that are, in many cases actually hit the news. And because they're so volatile, they're so fortuitous, what we're doing here is we're looking more at a risk-sharing layer rather than having every campus pay for their own claims. So here we just take the exposure, which again is that measure we talked about earlier. We take the exposure for each individual campus, and we use that to divvy up the amount of loss we expect in that excess layer. And then finally, that mid layer, the mid layer is kind of a combination. That $250,000 to $1 million layer, we have some losses in there, but they're also kind of volatile as well. So we use the experience to a certain extent, but we use the exposure as well to kind of balance it out and make it a little bit more stable. And we'll do some examples here to put a little bit more meat to the bones on that. When we do the 13-14 cost allocation, the experience and exposure that we use is for a recent 3-year period. Now for the experience, we're using 2008-09 through 2010-11, and the losses are valued as of June 30, 2012. So you'll notice that the 11-12 years is excluded from that calculation. Now the reason we do that is because it's the most recent year. We call it green because you don't have all the claims yet. You're still gathering information. You really don't know where those claims are going to end up. And so that first year is really a maturing period for the claims in that most recent year. So while those claims are maturing, we exclude them from the allocation calculation, and we just use the prior 3. So now let's go ahead and do the allocation. Based upon what we did earlier, we had a $48.7 million projected loss amount for 13-14. That breaks up into a primary layer of $17.7 million, mid layer of 14, excess of $17 million. Now again, that $48.7 million, that's what we're anticipating will happen during this next year based upon the loss rate that we anticipated and the expected risk-adjusted exposures we had, and we talked about that earlier in the presentation. So that $48.7 million is in total what we need to collect in order to collect enough to cover the new claims that will come in during 13-14. Those 3 pieces there are how we anticipate they'll break down into the various layers. And just like as I discussed each layer's allocation method, we'll start with the primary layer first, we'll do the excess layer second, and then we'll do the mid layer last because it's kind of a combination of the 2. So starting with the primary loss allocation, here's the $17.7 million that we just mentioned on that prior slide. Each campus, we have their incurred loss distribution in that first column. So just as an example, Davis has 17.7% of the total incurred losses in that first $250,000 layer. Therefore, since we allocate this primary piece completely based upon the experience, we will take 17.7% of the total, which is $17,725,000. You can see in that lower right-hand corner. We're going to take that number and we're going to allocate 17.7% of it to Davis, which ends up being $3,145,000. And all the numbers we're looking at here are in thousands. So that's our first step of the allocation. And we're going to repeat this a couple of times for the other layers that we're going to allocate. Again, the primary layer, we're just allocating based upon loss distribution. So now we go to the excess layer and we look at the exposure distribution. As I mentioned earlier, this excess layer is the highest layer of loss that we have, and there's a lot of volatility. And so rather than assigning claims to campuses individually, in this layer we're pooling all the risk. And so it's all being allocated to campuses based upon their exposures. Because a lot of times when you look at this layer of loss, you may have a campus that doesn't have any losses over $1 million in a given year, whereas others may have a huge loss in that layer in any given year. But rather than putting 0% weight on the campuses that don't have any and a ton of weight on those that do, here we share the risk. We spread it out based upon the physicians and surgeons and the occupied beds and visits that you have at each campus. So again, using the same thought process, Davis has 19.1% of the total exposures based upon the risk-adjusted exposure calculation we did. The amount that we're allocating in the excess layer is at $17,200,000 down in the bottom right. So 19.1% of that is $3,239,000. So now we have the primary layer allocated, which I'll back up one. You can see that's the $3,145,000 right here. Then we have the excess layer allocated, $3,239,000. Now we have one layer left, and that's the mid layer. And here, this is where we're combining both the loss distribution and the exposure distribution. So here, the loss distribution is actually the distribution of losses in that $250K to $1 million layer. And of those, Davis has $14.6 million. Now the exposures here, you'll notice, are the exact same distribution as on the prior slide. If we back up one, you'll see Davis has 19.1 there, and in this slide, it's also 19.1. So we're going to weight those together, giving 40% weight to the 14.6, giving 60% weight to the 19.1, and that gives us a weighted distribution of 17.3. So what we've accomplished out of all this is we've combined a method of giving some weight to the loss experience in this layer, only 40% of it, and assigning some weight to the exposure distribution, the FTEs, the beds, the visits, and used both of those to estimate how we distribute these costs in this middle layer. And so for Davis, they get 17.3%. We're going to allocate this $13.962 million to each of the campuses based upon their percentages, 17.3% of which is $2,413,000. So those are the three different layers that we're going to allocate. Now if we move on to adding all the pieces up, you'll see from each layer, here's the $3,145,000 for Davis in the first primary layer. We have the excess layer allocation, and then we have that mid layer allocation. So in total, we expect Davis to have $8.797 million out of the $48.689 million total. So everything we've done here, the only purpose of this is just to get a way of distributing the total amount of cost down to each individual campus. And we're doing that based upon their historical experience and their exposure. And so if we follow the bouncing ball here, you'll see the 48.689 comes over here to this first column on the next slide. And just like I said, all we're using this number for is to derive a distribution by campus of the grand total. So you can see Davis has 18.1% of the total. Now the total amount that we're allocating this year is $53.8 million. That came from the very first part of the presentation where we went through and calculated the 65% confidence level losses. We added onto that some loss prevention expenses. We added on TPA expenses and insurance. And the grand total for 13-14 was $53.86 million. Now 18.1% of that is $9,734,000. So that's ultimately what we're using this for, is we're taking this grand total of $53.8 million and we're allocating it to each individual campus. So that is how the self-insurance program works. There's a lot of steps, but I think you'll agree it was really pretty easy and pretty fun. So before we jump on to the next part of the presentation, we'll do our final tour through the graphs. And you know, it's always fun to talk about music. I think you can express the music very well in graphs. Here's the lyrics to Batman, and for those of you who are old enough to remember the old Batman show, this is pretty much how that song went. There was a whole lot of things besides just Batman. Now, for those of you who were excited about music during the 80s, These are some things that Rick Astley would never do. He'd never give you up or let you down or run around and desert you. He'd never make you cry, say goodbye, or tell a lie and hurt you. You'll notice that's a verse right out of the song, if you can remember it. If not, I know you can remember this one, the Macarena. There's a whole lot of words in there that nobody really knows what they're talking about. But everybody joins in at the A Macarena part. So we're now on the home stretch, heading towards our final graph, and we're going to focus on private insurance. Now, private insurance, we have three main carriers in California that provide healthcare professional liability. The Doctors Company is the largest. They recently, and when I say recently, it's been within the last few years, they purchased Southern California Physicians Insurance Exchange, which called Skippy. That was a Doctors Company was predominantly Northern California. Skippy was predominantly Southern California. So the Doctors Company now has very, very extensive coverage throughout the state. The other two main companies that provide insurance in the state are NorCal Mutual and Medical Insurance Exchange of California, or MIAC. So those are your main carriers. The typical HPL coverage that you get from a med mal policy, you're going to have the coverage for your medical and surgical specialties, so internists, allergists, OBGYN, surgeons. They're all going to have their typical coverage. They're going to include defense, just as does the self-insurance program for UC. One thing that's not a standard inclusion is coverage for the entity or for the hospital exposure. That is available for an additional premium, either on a hospital basis or for the entity as a group practice. The one thing about the UCOP self-insurance program is all of these coverages, all of these exposures are included in the program. So there's coverage for all of those exposures. The other thing that's notable about the typical HPL coverage that's in the market is that it's offered on a claims-made basis. Now what that means is that your coverage is provided when the claim is made. So you may have had a claim that occurred 2 or 3 years ago, or an occurrence that happened 2 or 3 years ago, but did not turn into a claim. And then ultimately, over time, the patient started having problems and decided to file a claim. So the claim has occurred before, but it's just now being filed. So for a claims-made policy, that only covers claims that are reported during the policy period, but the accident date has to be after a retroactive date. And so a retroactive date is an important piece of the claims-made policy. Let's say you were a first-year doctor, you bought a policy on a claims-made basis, and you didn't have your retroactive date was the effective date of your new policy. If you had a claim with an accident date that occurred before you bought the policy, you would not have coverage under a claims-made policy. Now you can purchase coverage for prior retroactive dates, and again, that's an additional premium. Once you have a number of years of claims-made coverage, you've had a claims-made policy a number of years in a row, your policy becomes what's called a mature policy, in that for the most part, whatever new claims you're going to have reported during the policy period, they will have occurred after the retroactive date you started. Now the other problem is if you cut off coverage on a claims-made policy, you still have claims that may have occurred, but they haven't been reported yet. But since they haven't been reported yet, they're not covered if they're reported later. And so if you cancel a claims-made policy, you need to purchase tail coverage, which is an additional premium and provides you coverage for claims that occurred prior to your cancellation date but are reported afterwards. So you kind of have 3 different costs involved in the lifetime of a claims-made policy, whereas for comparison on UC, their coverage is on an occurrence basis. So if you have a policy effective during 13-14, and there's an accident that occurs during 13-14 that generates a liability, that claim could be reported during 13-14 or 10 years from now, and it would still be covered under the current policy. And so that's one thing to note. You're typically going to see claims made in the market when you're shopping around, as opposed to the occurrence-based coverage. And then another key thing to note about the standard HPL coverage is the loss limits are typically for a $1 million, $3 million limit, which means $1 million per claim, and there's a $3 million annual aggregate per physician. So, you know, the $3 million limit comes in less in play because the likelihood of you having multiple million-dollar claims in a given year is pretty remote. But again, your standard policy is only going to offer you $1 million of coverage. Now, you can purchase higher limits for an additional premium. So on top of that $1 mil, $3 mil policy, you can buy it up to $5 million, $10 million, but again, you have to purchase it for additional premium. Now again, the UC program takes you self-insured up to $5 million, and you know, on an insured basis beyond that. So that's a key thing to note, is that your loss limit in the market is going to be much less than what you typically are afforded within the UC self-insurance program. So we'll do a quick premium comparison of the cost of self-insurance versus private insurance, and it's kind of hard to do an exact comparison because there are some differences with the coverage. Because when we do the analysis, we don't break down the costs of the UC program between hospital and non-hospital. We lump it all together. So the coverage, the premiums that we're going to use in the comparison here include hospital, whereas the private insurance premiums exclude hospital. So again, there's more coverage being provided on the self-insurance program that we're comparing to the private industry. Now, the coverage basis, self-insurance is on an occurrence basis, private insurance is on a claims-made basis. Again, we don't keep track of the self-insurance program costs on a claims-made basis, so we're just going to show it on an occurrence basis, which again is more expansive coverage than what you get on a claims-made policy. And then finally, the limits. The standard limits that you see in the rate manuals for private carriers are 1 mil, 3 mil, whereas the self-insurance program that we have with UC, self-insurance is up to 5 million. Excess insurance takes us up to at least 200 million, and so there's a lot of coverage there in addition to the typical 1 mil, 3 mil. But again, because the coverage, the insurance includes excess of 5 million, we don't really break things down any further down to 1 million. The self-insurance program is actually 5. So again, there's more of a limit going to be included in the premiums that we compare for the UC program. And so here is the results of a quick premium comparison using the manual rates in these companies' premium manuals. We show it here by campus and in total, and probably the best thing, we'll just look at the total line. You can see that TDC, the doctor's company, in total has the lowest premium of the private insurance carriers. MIEC is second, and NorCal is a close third. On average, it's about $116 million for premium. And then the self-insurance program for UC is $52.9 million. And that includes all of the coverage expansions that we just mentioned on the prior page. That you have occurrence coverage, that you have higher limits, that you have that the basis is occurrence, and that you've got hospital coverage in there as well. So the self-insurance row has additional coverage, but you'll note that the total premium is significantly lower than the manual rates provided in private insurance. So in total, it's about 55% savings off of the manual rates to get you to a self-insurance cost. Now if we look at a graph that kind of shows how everybody stacks up, again you see the UC is by far the lowest. The self-insurance program is by far the lowest of all, in spite of the coverage additions. Doctors Company and NorCal and MIEC are shown after that, and Doctors Company pretty much across the board is the lowest of the carriers. MIEC and NorCal kind of switch back and forth. Now, why do we have such a cost difference? Well, there's a few things we can point to. We've got the private carrier premiums include commissions to pay the agents for selling the policies. There are premium taxes that are taxed at a different rate. Also, when you build in when you develop a rate for private carriers, there's also a profit load included, and those are not included in self-insurance, as we're really trying to break it down just to the necessary costs to run the program. Now you've also got the claims within self-insurance are administered by the TPA and monitored by risk managers. So you kind of have, within the self-insurance program, you have your hand in the claims process quite a bit. You know what the claims are, you're getting regular reports, whereas with an insurance company, they're typically, they handle the claims themselves. They're typically going to be at the will of however they're handling their claims. Now another item is loss control. Now within UC you have ERM, you have a tremendous amount of loss control and loss prevention initiatives that are being put into place or have been put into place for a number of years now, all of which are intended to keep costs down. And that's what they do. You have these loss control measures that where you've got folks within the UC system that their entire job is for the purpose of reducing risk. And so when you buy a private policy, you do typically get some loss control services, but nothing near what you're getting currently from the internal program that you have set up. Now the one thing that needs to be mentioned though, when we do these premium comparisons, that private carriers typically group rate large entities such as UC. Now that will reduce the difference in the premiums that we saw on the prior page. The one thing to take note of though is that you've got everything that we've included in the premiums is a coverage expansion for the self-insurance program. So even the savings that you would get from group rating, you still need to increase the premiums on the private market side to account for increased limits, conversion to an occurrence basis, and addition of hospital and entity exposures for the program. So granted, you're going to reduce the difference. The savings will not be as significant as the 55% overall that we looked at previously, but you can rest assured that the savings are still going to be significant after all the adjustments would be made. So with that, do we have any questions?
Lines are open. Anybody have any questions they'd like to ask?
Any questions?
Mike, we did have a question in the chat box earlier from somebody who wanted to know if it would be possible to get a copy of the spreadsheets used to arrive at these calculations.
Which calculations?
Let's see. Laurel, are you on the line at the moment?
Yes, I am.
Oh, good.
Thanks.
Yes.
Hi. There's several sides on the expense loss, what do we call them, expense loss distributions and allocations. The scenarios of the under 250, the over $1 million, and then the averaging of those. I appreciated your explanation, but I couldn't write it all down, so it would really help me to get at the spreadsheets.
Sure. The report, I believe, is posted on the risk management website, the latest actuarial report, which would have all the calculations and everything detailed within it. Let me see if I can figure out where that link is, and I'll make sure you get that, Laurel.
Thank you.
Well, if there are no further questions at this point, I think we'll wrap it up. Thank you, everybody, for joining us. Thank you very much for the presentation, Mike. We will be uploading this to our website with the others. I'll send out a notice in a day or so letting you know where they are. And we hope to see you for next month's Toolbox webinar. Thanks very much.
Thank you.
Thanks, everybody.